Good afternoon, everyone. Thank you for joining us. I would like to thank you for joining us today. I'm Katie Capps, the co-founder and executive director of the Medications Right Institute. Before we get started, I wanted to congratulate the Institute on achieving a real milestone. We are 1,150 members representing close to 750 companies nationwide. That membership has been invited to join our membership feedback calls. We started the calls last week and we will continue the calls this week. Each of these events will highlight steps to be taken around medication management reform, focused on 4 key areas: how we use diagnostics, how we integrate technology, how we pay, and how we practice. In July, we released the GTMRX Blueprint for Change, a robust report based on multi-stakeholder input, offering guidance for how to change the way medications are managed and used. It's our roadmap for reform. If you've not read it, you will find it on the GTMRX website. I want to thank the board members of the Get the Medications Right Institute. They offer strategic direction and support and serve as board sponsors for our work groups. I would also like to thank GTMRX executive members and our strategic partners who support us through their leadership and funding. And finally, I'd like to thank the GTMRX staff. They do tremendous work. We're a small but mighty team, and they work very hard every day. So some quick housekeeping tips before we get started. If any technical issues arise during the event, you should contact Natalie Cromwell. Her contact information is listed here. All participants will remain muted throughout the event. To ask questions, just use the chat box. General questions should be directed to everyone, and I will ask them during the Q&A period. As the moderator, I will ask you, the audience, questions, and we ask that you respond back to everyone in the chat box, noting question 1 or question 2 responses. We'll gather that information at the end of the webinar in order to inform the workgroup activities as we move forward. Now, how we pay for care is important, and medication management reform requires that we change how we pay for care. Prescription drug spending exceeds $300 billion a year. And while affordability of the drug product is important and access to the product is important, we have not had discussions around appropriate use of medications. To do this, we need to pay for a process of care or a service that ensures that the medications being taken are appropriate for that individual. Medication selection and management matters. Our goal at the Institute is to align payment and policy to reward for a process of care that will answer, is this the right medication for this person? We believe that optimizing medication use through comprehensive medication management and practice is the way to achieve that goal. Comprehensive medication management is a service that can be delivered across the continuum of care and through a variety of modalities, face-to-face, telephonically, via telehealth. Our Payment and Policy Solutions work group, including the 2 subgroups, payment methodologies and telehealth delivery of CMM, have been hard at work creating guidance and tools to expand access and adoption of these payment solutions to reward and encourage adoption of CMM in practice. And I want to thank them for their hard work. Presenting today is Bailey Larson and Marianne Clathermas from ASHP. They will both give brief updates on the workgroup activities, and then I'll facilitate our member feedback session with support from Larry Lamont of the California Chronic Care Coalition, executive member of the Institute, and Kathy Pham, co-lead of the Payment and Policy Solutions work group from ACCP. I'll now turn it over to Bailey.
Hi, everyone. Thanks so much, Katie. As Katie said, my name is Bailey Larson. I'm Strategic Initiatives Associate at ASHP. Also on the line is Larry Lamott, Senior Policy Advisor for California Chronic Care Coalition. We are the co-leads for the Payment Methodology subgroup. I'll be presenting for Larry and I today on behalf of our subgroup. Our 12-person group is comprised of motivated individuals representing different practice settings, including payers, health systems, clinicians, advocacy groups, and professional associations. The subgroup was formed from the Payment and Policy Solutions Workgroup to work to create a value-based payment framework and model for CMM. Right now, a majority of our healthcare is still based on the fee-for-service model, which is not sustainable, and there's a gradual movement towards value-based care and payment becoming the majority. Gaps still exist that the work group seeks to identify and address so that all patients can have access to the best and most comprehensive care. Next slide, please. So the subgroup is tasked with exploring current and new payment structure solutions for CMM and creating a value-based payment framework and model. Over the past 6 months, we have explored value-based frameworks and methodologies. We know that value-based care programs lead to better care for individuals, better health for populations, and lower cost. CMS currently defines value-based care as paying for healthcare services in a manner that directly links performance on cost, quality, and patient experience of care. Value-based care can be translated by some institutions as the triple aim, which is made up of better patient outcomes, improved patient satisfaction, and lower costs. The triple aim has since been expanded to the quadruple aim, which includes physician and healthcare professional well-being. We also heard from guest speakers and experts, including Dr. Wendy St. Peter, who shared her work on the Advancing American Kidney Health Through Optimal Medication Management initiative. Next, we identified key stakeholders and their values to facilitate engagement and buy-in towards the adoption of CMM. We reached out to all these stakeholders and got a great response from each group. We sought out people from across the spectrum of healthcare, including those in other GTMRX work groups. Finally, we articulated the value CMM brings to the healthcare system and how it's measured by each stakeholder. Next slide. As we've worked to develop this value framework, we gained insights from each other and the process. First, we realized that there are wins for every part of the healthcare system when CMM is fully integrated into providing care. This includes members, providers, pharmacists, healthcare organizations, and payers. High-quality clinical services that improve outcomes and reduced overall healthcare costs are provided by CMM care teams throughout the country and in different practice settings. Their value is definitely recognized by their colleagues and patients. We realized and appreciate that organizations such as GTMRX provide a key role in raising the banner for recognition by national payers. And finally, diverse stakeholder perspectives have elucidated shared challenges and areas of alignment. Next slide, please. The first thing we did as a group was draft a value proposition, which was the groundwork for the framework. The value proposition is that comprehensive medication management improves patient safety, patient lives, and health outcomes while avoiding unnecessary costs and saving money for the overall health system. We then created an outline to encompass stakeholder perspectives. The framework shares the values of these stakeholders within the proposition. Stakeholders included patients, caregivers, patient advocacy organizations, employers, clinicians, health systems, just to name a few. The value framework we have created will be used to inform the larger work group, inform messaging, and be a reference document as the payment and policy work group moves forward to develop a payment methodology. Next slide, please. So now that we know the values of each stakeholder group in regards to CMM, we can move forward to work toward a payment methodology, making sure that all of these values are upheld. By articulating the value that CMM brings to the healthcare system and how that value should be measured by key stakeholders and organizations, we can start to facilitate system-wide adoption of CMM. So thank you so much for your attendance and attention. I look forward to questions and discussions at the end. I'll now hand it over to my colleague, Marianne Clethermis.
Thank you very much, Bailey. I'm Mary Ann Clee-Thermos, and I am currently Director of Medication Safety and Quality at at ASHP. And before I get started, I'd like to acknowledge our work group. And as Bailey said, we were formed in a very similar manner to hers. And I'd like to thank my group for their dedication and hard work in getting us to where we are at this point. Next slide, please. So our charges for our work group, we're really focused on CMM via telehealth, and that is to identify successes and barriers, to develop a framework, and to collect resources or collate resources for implementation and expansion of CMM and telehealth. And then finally, to provide guidance and IT requirements and documentation of services. We have been able to work on the first three and have not gotten to the last one as of this point. What we have accomplished so far. We conducted a very comprehensive literature review that went back 20 years. And in that, we were able to identify 42 citations. And if you think about how telehealth has exploded since the COVID pandemic, you can expect that that will probably greatly escalate. Of those 42 citations, 2 were white papers, there were several review articles. We were able to identify 14 citations or manuscripts that moderately met or completely met CMM to guide us as we move forward. And we use those citations as well as our work group's experience and some of the gray literature to identify barriers in providing CMM via telehealth. And then we moved forward after we completed that to developing a very comprehensive outline to create a framework on how to provide CMM via telehealth. The framework will address the value to all of our stakeholders, providers, patients, and payers, explore the barriers, as well as some of what we've learned and how to integrate CMM and telehealth as we move forward. Next slide, please. So what have we gained? Well, certainly telehealth is a technological modality that offers promise. And I think the energy that we're seeing around telehealth currently from COVID really reflects how the healthcare system had to pivot, taking care of patients, including complex patients via this modality. And I think most experiences have been positive. We've been able to take care of patients, and in fact, the ingenuity of many of the providers able to figure out how to do some physical exam, how to take care of some very complex patients using this modality. So the interest definitely is there. The other thing that we learned from our research, as I mentioned, we went back 20 years, is that telehealth is not new. It just was not common until now. And there is really a valuable experience published from organizations such as VA and integrated healthcare models that have used this modality. And mostly they have provided positive outcomes. Out of our literature search, out of those 14 articles, there was only one that didn't show a positive outcome. The rest of them all, in the particular specific measures that they looked at, they did. We also learned that most people have probably heard about, our barriers definitely exist. The greatest are those around technology, that being the lack of access, either provider, but mostly patients, to broadband, Wi-Fi, having the software or the hardware needed to successfully run such kind of visits. So that's definitely an area that needs a lot of work. Also, there's some barriers to acceptance. There are definitely providers and patients who prefer the face-to-face. Although there's a lot of patients and also providers who understand that convenience that is associated with this modality and providing services. And also payers are a little bit skeptical, including CMS, as to whether this opens up more avenues or harder to evaluate whether there's fraud and abuse occurring in such modalities. And then finally, reimbursement is a major barrier. There are no good, clear models of reimbursement for these types of services. And additionally, what there is may not be sufficient to maintain and sustain such kind of services. Next slide, please. So what have we got? So far, we have this evidence that supports the use of telehealth in the provision of CMM. And I must say that half of those articles with positive outcomes were telephone only. As you recognize that they went back fairly far, 20 years ago. So we do have that to build off of. And then we have in progress this framework for providing CMM that we hope stakeholders can use to actually support and develop CMM via telehealth. Next slide, please. So what are our opportunities to move forward? Well, I think telehealth, as most people would say, is here to stay. Is it going to be completely take over face-to-face visits? No. The number that I've heard people throw out is that it may be in that 20 to 30% of all visits may be via this modality. So we certainly want to develop the support and evidence that CMM be a standard reimbursable service that could be provided through telehealth. And I think we also need to evaluate the different modalities to understand who should get telephone or who can, and where is it effective in telephone delivery, and where should it go to a more complex modality such as audio visual. But we'll need to understand that, and which is the best and how best can we give to CMM services and to which patients. So those are our opportunities as we move forward. And with that, I'd like to turn it back to Katie for questions and answers and feedback.
Thank you, Marianne, and thank you so much, Bailey. As I mentioned before, the work of the Institute is so reliant on volunteer leadership, and we appreciate all the hard work that you and your work groups have been doing. I want to just make note to the audience, these questions that we have showing on the screen are questions that we ask that you answer back in the chat box. When you're answering question number 1, just note it Q1 and offer your response back to those questions. We may or may not have time to go through all of these while we do a feedback session. Your input is extremely important. The documents that Bailey and Marianne shared with you, the value framework and the initial outline for the telemedicine additional work that will be done, were sent to you as part of your meeting reminder. So there is a link to the draft of those documents in your meeting reminder for this session today. So Bailey, how can the Payment and Policy Solutions subgroup continue to advance CMM through use of this value framework? What are your views as it relates to that and the rest of the group's views?
Sure. So I think the value-based framework and value-based proposition are fundamental to value-based payment. So in regards to advancing CMM, the framework showcases the value to stakeholders within that proposition. So when we develop model payment methodology, we want to make sure that these values are being upheld and reflect the values. So knowing that these will be incorporated to a payment methodology with that original value-based proposition, I think is how we continue to get it to move forward.
Can you outline some of those stakeholders that were covered within the value framework for those that may not have reviewed the value framework document?
Yeah, of course. We covered quite a lot. I know when we released the survey, people had other ideas what were to include as stakeholders. We had clinicians, we had patients and caregivers. We had manufacturers, government. Larry, I know I'm probably missing a few here.
Employers.
Employers was a big one, yeah.
Yes.
Right.
And payers, you said payers, so.
Yeah.
Employers is health plan sponsors, I suspect. So Marianne, Bailey, upon completion of the value framework, what are the next steps of the payment methodology subgroup? This may be Bailey, a question to Bailey, or could be a question to Kathy Pham, who I think is also joining us during the Q&A period as well.
Yeah, I think we really want to, start to identify specific attributes of successful payment methodologies. and how they interact with the value framework we have developed. So we now know the values. We want to make sure that they're upheld as we evaluate new payment methods focusing on patient outcomes.
Thank you. Kathy, did you want to add anything to that?
No, I think it'll just be important as the work across work groups in Get the Medications Right Institute informs, specifically related to payment methodologies. You will still need the quality metrics and various other pieces to monitor the value that you hope to gain. So I think that this is an opportunity for collaboration across those who focus a lot on payment and policy, as well as those who focus on practice advancement or practice transformation initiatives, that those one will inform the other greatly, and to make sure that those are aligned.
And I think it's important to know, because you guys have really been mindful of making sure that the demand side, or employers as health plan sponsors, or health medical carriers or health plans, that you consider the values from that standpoint, as well as the supply side, the providers of care, clinical pharmacists, primary care physicians, specialists, et cetera, that those are also considered, as well as consumers, as it relates to the consumers find of value from a CMM standpoint as well. So this has been really good work, and you guys are to be applauded on establishing the initial stages of that. So, Mary Ann, how does the value of telehealth provided via CMM, from your standpoint, your work group standpoint, differ from the value of CMM provided in a face-to-face encounter? Or what have you found through some of the initial review of the literature?
Well, actually, there was one study that we did pull out that was with CMM that actually looked at that very question. It was done in the VA, and it showed no difference. It said the outcomes that they used to measure were the same, and what they did show is that they actually needed less FTEs to provide the telehealth, which was an interesting finding in that. So it appears, and the rest of the studies just looked at telehealth and didn't compare it to face-to-face. But when we look at the outcomes they measured, and they were the typical outcomes of blood pressure, hemoglobin A1Cs, and that, lipids that we tend to see in CMM outcome results, they tended to be about the same as face-to-face. So it looks like, very small number of studies, but still it looks like there is no difference. So that I think we can pretty much use to move forward on.
And we are so fortunate to have such an active involvement of the VA as part of our work groups and our work group leadership as well. So I think it's important to point out one very advanced delivery system as it relates to that. Mary Ann, from your standpoint, how does the current COVID-19 environment change telehealth and or CMM care, or access to CMM care?
Well, I think it probably proved to a lot of providers that they could provide it via telehealth. I think there was probably resistance to change. I mean, that's kind of typical human nature. And so I think, we've been able to see a lot of different kinds of services be able to provide telehealth. And there were some advantages where you could see how that the environment, the social environment where the patient is, that can help explain things. I had one practitioner tell me that they were going through the person's meds, which they never brought in, but could see it at the house. And they actually saw one that they had no idea after taking care of this patient for 3 years that they were on. So I think there's some advantages, and that's probably why what we'll see in the future is going to be a hybrid. There will be some telehealth, and there will be some time when you need to bring them in, and we're learning, I think, when that will be and how often they'll need to be, because there probably will be some need for face-to-face. There even, with technology, we'll probably even see the patients be able to do some of their own physical exam that you may do as part of your visit. So I think we learned a lot. I think we will learn much more. I think there are 3 major journals that I'm aware of that are planning telehealth issues. And so when those come out, it'll greatly enhance our understanding and knowledge to these questions.
Thank you. And we're getting questions from the audience that I want to try to make sure that we get to as well. And this question is for Larry or Bailey. What kind of outcome and process measures are being followed to demonstrate value when you consider optimizing medication use through CMM in practice?
We are still identifying some of those matrices, and we'll continue. That would be part of the next thing. We wanted to first get down what are some of the values that stakeholders have that are important to them in order for CMM to be successful, and having an integrated team and working together and having everybody at least agreeing on the same outcomes. You know, the thing with value-based healthcare is that the bottom line in that is you have to use and look at the outcomes to patients. The patient outcomes is very important. And that's what distinguishes, I think, the value-based healthcare issue. So we have identified, and we will continue to identify in terms of when we're putting together the methodologies, we will have to come up with the various types of components that the questioner had brought up. And
I'm sorry, Larry.
That will be going forward, hopefully in the coming months.
Thank you, Larry. And to Larry's point, and then this picks up on what Kathy Pham mentioned earlier, we do have a metrics subgroup. Their presentation will be later on this week. And the value framework that Bailey and Larry's subgroup have developed will help inform the type measures that each one of the stakeholder groups recognizes as being useful and of value. So I do want to mention that to this work group. We're working very hard to make sure that the outputs from these work groups cross-inform outputs from other work groups. At the end of November or the 1st of December, we'll be releasing about 10 guidance documents as a result of the current work that's been done. And you will see over the coming months, we'll also release additional documentation on that, or guidance documents from our terrific leadership of all these work groups. So the next question is to Kathy. Kathy, are there current examples of fee-for-service payment methodologies for CMM in practice? And then a second part of that question is, are there current examples of value-based payment methodologies for CMM in practice in a value-based payment model?
Sure. And I may not have the most comprehensive list of these types of models available, but what I can think of as examples are with fee-for-service, and I'll actually direct the comment in the chat box related to whether or not fee-for-service can really be structured to reward CMM. So I think that's a good, careful caveat to keep in mind as we think through this question. What CMM, when providers of CMM don't have the structure or code to bill, I think they just work with what they can, what's available. And in this case, for fee-for-service, in the physician fee schedule, that's the incident to billing and the chronic care management codes. However, those can sometimes be very variable in the level at which you can bill, particularly if you have a much more intensive intervention versus a shorter or more brief visit with the patient. And unfortunately, there's just not a national standard and consistency, particularly when it comes to regional Medicare, Medicaid administrators and billing. So although I think that there are CMM providers that make do with some of these fee-for-service codes, it's not always consistently reimbursed or compensated, and that can cause a lot of ambiguity and confusion, not just from region to region, but even sometimes within the state. It's very hard to get a consistent approach to payment there. Related to value, oh, go ahead.
Oh, go ahead, Kathy.
Okay. Related to value-based, I think that's still very much evolving, and that's part of why I think the work of this work group is so important moving forward. I think that there have been a lot of pilots and demonstration projects that have set the foundation for us to continue to improve on how CMM can be rewarded in value-based purchasing models. But it seems like each model informs the next one. So where you may have seen in Southern California, the CMM pilot programs out there that I'm sure helped to inform a little bit of what then CPC Plus was able to roll out in their Track 2 requirement for implementing CMM. And then we now see even the Maryland Primary Care Program learning from the CPC Plus module and trying to address some of those limitations of small to medium-sized practices being able to implement the service. So I think that that is something that each model builds upon each other. And even though that's continuing to evolve, I think that particularly in CMMI, there are some opportunities, and I think it'll be important moving forward to keep a watch for other CMMI initiatives where if CMM is not already explicitly considered as a requirement, that there are initiatives that really align well with that comprehensive care team-based model.
Thank you, Kathy. And for those of you on the call, if you have examples that you would like to share with us, please respond back in the chat box or on the survey that you'll receive after this event. Unfortunately, we only have time for one more question. We're going to stay just a couple of minutes over. And this question, Marianne, goes to you. How do we overcome the digital divide that has been exposed as a result of this pandemic? What will it take to make the digital divide as part of a routine social determinants of health measurement?
Yeah, that's an excellent question. And fortunately, this week, Bailey and I listened to a government webinar telecast where this was actually discussed and was brought up, and I just put it in the chat box, is that the reason why we can all communicate by telephone was a federal initiative under the New Deal. So when that form of communication came about, just like we have a highway system, the federal government made sure that we had a communication system via telephone. And we may need to have something along those lines, taking into account that it's affordable, like most people could afford phone service. And so we will need to probably have a federal policy initiative, much like the New Deal was under Roosevelt, and much like telephone service, we don't even think about it. Telephone service is available everywhere. May need to do something like that. Otherwise, I don't know that that's, if we leave it up to each state, that may not work. This is really something I think we can advocate on a federal level.
Well, we've certainly seen through the pandemic, not only the need for that, but the opportunity for that. On behalf of the Get the Medications Right Institute, I would like to thank our presenters, Bailey, Marianne, Larry, and Kathy, and also thank the rest of the Payment and Policy Solutions work group and subgroups. I also want to tell our listeners that we will have our final member feedback call on November 19th on practice transformation. And I would encourage those of you that are on the line with us today, you can still register to participate as part of that. And that will be output from the metrics group, as I mentioned to you, and the evidence group as it relates to activities that those work groups have been working on. Please fill out the survey that you will receive. You should be receiving it now after today's session, so we can get further input from you as it relates to not only the items we've discussed today, but in response to some of the questions that were posted today. I invite you to visit the GTMRX website and download our latest report, Blueprint for Change, calling for medication management reform. And if there are those of you on the line that would like to participate in any of these work groups, please send that information to us on your response survey. Join us on Facebook, LinkedIn, and Twitter by searching GTMRX Institute. With that, thank you for joining us today. Thank you for the leadership that's on the call today. And until our next member call, be well.